GlomCon seminar series. Today, our talk is Targeting Glomerular Injury with Sparsentan to Preserve Kidney Function in Patients with IgA Nephropathy. Our speaker today is Dr. Chris Gisler. He is the Medical Director at Travere Therapeutics. Following his talk, we'll have a panel discussion with Dr. Dana Rizik, a professor of medicine at the Division of Nephrology at the University of Alabama at Birmingham, and Dr. Swati Arora, an academic nephrologist at Allegheny Health Network in Pittsburgh, Pennsylvania. Before we start our seminar, I'd like to acknowledge the global effort that GlomCon has become. We thank all our participants, those behind the scenes, and today we'd like to take a moment to thank one of our corporate sponsors, Travere Therapeutics. Travere Therapeutics is a biopharmaceutical company whose mission is to identify, develop, and deliver life-changing therapies to people living with rare diseases. The recent approval of Sparsentan has advanced therapeutic options for adults living with IgA nephropathy. We're thankful for their support and for your support now and in the future. And with that, I will turn it over to Dr. Gisler to share and begin our presentation.
Thanks so much. Here, let me bring this up. All right. Thanks so much again, Dia, for having us and supporting us here today so that we can give this presentation. And like you said, we're going to start talking a bit about Sparsentan today and using it to preserve renal function in our patients with IgA nephropathy. So just a quick agenda here. We'll start by just talking about the need for optimized kidney-targeted therapy to achieve lower proteinuria goals in order to preserve kidney function in our patients with IgA nephropathy. Then we'll spend some time talking about the benefits of a DIARA, which is a dual endothelin and angiotensin receptor antagonist to treat IgA nephropathy. We'll then go through the PROTECT data initially, and then kind of the most exciting part, I think, is share some of our newer data that we presented at ASN just earlier in October. So starting out, patients with IgA nephropathy do require optimized kidney-targeted therapy to mitigate glomerular damage. And I think these are kind of points that you all know very well, but obviously the patient population that we're dealing with IgA nephropathy is a younger population. So mean age of diagnosis is 41 years. And we know that the majority of these patients, are all at pretty high risk to develop end-stage kidney disease within 10 years of diagnosis. So being aggressive and treating them obviously very important, right? And we know that about 3/4 of the patients, when we see them, unfortunately, already do have moderate to severe CKD, so stage 3 or worse. And so really even our time frame to make a difference is markedly shortened because when we get to see them. So we know that proteinuria treatment really is the goal to target in order to try to preserve kidney function in these patients. And that was outlined very well by the KDIGO draft guidelines, which were reviewed earlier this year with the final guidelines expected sometime next year. But the call out here really is the green box, which basically is talking about the proteinuria guidelines. And this was sort of a shift in mindset, right? Where now we're thinking that we really need to target proteinuria to go as low as possible. So the recommendation is less than 0.5 grams per day, and even preferably less than 0.3 grams per day to try to protect these patients with IgA nephropathy who are at risk of progression. And the thought is that by doing that, we'll hopefully achieve our treatment goal of reducing that rate of kidney function loss to less than 1 milliliter per minute per year for the rest of that patient's life. So one strategy to consider when we're trying to achieve these goals is directly targeting kidney injury. And that's where a DIARA, or a dual endothelin and angiotensin receptor antagonist, does come into play. And so that's where we're going to talk about Sparsentan today. So Sparsentan works directly at the kidney to preserve renal function. And we know that in IgA nephropathy, when the immune complexes deposit in the mesangium of the kidney, that causes upregulation of endothelin and angiotensin. Now, both endothelin and angiotensin are damaging to multiple sites in the glomerulus, including the podocytes, the glycocalyx. And ultimately, these two together upregulate each other. So endothelin upregulates angiotensin, and angiotensin upregulates endothelin. So you kind of have this storm of damage that's occurring, in the kidney. That's what's represented in the center circle there on the top. Now, where Sparsentan comes in is it's a single molecule that can bind to either of these sites. Now, its binding to the angiotensin 1 receptor is always greater than binding to any of the endothelin receptors. So we're always getting maximal angiotensin blockade with sparsentan. We also know that it blocks the endothelin A receptor as well. And so again, by blocking those two receptors, we've shown in mouse models that sparsentan can be anti-inflammatory, anti-proliferative, and anti-fibrotic. We're also starting to collect additional data now to show that and demonstrate that in humans. And as we see here below on the right, sparsentan also has very strong anti-proteinuric side effects. I should also mention that sparsentan has no affinity for the endothelin B receptors. And so those are typically the ones associated with edema, and so it has no affinity at all for that receptor. Then we move on to sparsentan's indication. And one thing to highlight is that this fall, sparsentan received its full approval. And so now the indication statement reads, it's an endothelin and angiotensin 2 receptor antagonist indicated to slow kidney function decline in adults with primary IgA nephropathy at risk of disease progression. The two major changes that we had in our indication statement were, first, we now have an indication to slow kidney function decline. During the accelerated approval, the indication was to lower proteinuria. So now, because of our 2-year data from PROTECT, we do have that indication to slow kidney function decline. The other thing to note from the indication statement is that the proteinuria requirement was removed. So initially it said people at risk of progression, generally with more than 1.5 grams of proteinuria per day. That's been removed now. And so really it's more in the clinician's discretion as to which patient you believe is at risk of progression, regardless of sort of that level of proteinuria. So you don't need to wait for these severe cases. You can treat at lower proteinuria levels. And later in this presentation, we'll actually show you some success we've had with those types of patients. We'll start with our initial PROTECT 2-year safety and efficacy results. Now, as a review, PROTECT was a randomized multi-center trial where sparsentan was compared against an active comparator. So the other IgA trials are really comparing patients to placebo. So with sparsentan, the trial design was a bit different and a bit unique. So prior to being enrolled in the study, patients had to be on a maximized dose of an ACE or an ARB for at least 12 weeks prior to screening. And this dose had to be at least 50% of the max approved or max label dose. So they had to be on a max tolerated dose for them, but it had to be at least greater than 50% of that label. Then they were randomized in a 1-to-1 fashion to either receive sparsentan or irbesartan. And for the first 2 weeks, they were on either 200 milligrams of sparsentan or 150 milligrams of irbesartan. At that 2-week period, they were then force titrated up to 400 milligrams of sparsentan or 300 milligrams of irbesartan. And so in that way, that's where we have that active comparator. So this kind of is a little bit different probably than what was done in real practice. Certainly myself as a community nephrologist, I was probably not aggressively pushing my ACEs and ARBs as high as maybe I potentially could have or should have. But in this study, we're comparing sparsentan at a max label 400 milligram dose to irbesartan at a maximum label 300 milligram dose. And we see there at the bottom on the left side, for the irbesartan cohort, 96% of patients that received irbesartan were on that max label 300 milligram dose. We are really comparing sparsentan to max label irbesartan. Our primary endpoints were the change in the UPCR from baseline to week 36. And some key secondary endpoints were looking at the GFR slopes as well as the rest of the proteinuria data. We kind of briefly mentioned these, but the inclusion criteria, you had to be an adult with biopsy-proven IgA nephropathy with more than 1 gram per day of protein excretion. Your GFR had to be greater than 30, and you had to have a blood pressure, a systolic pressure less than 150 and a diastolic pressure less than or equal to 100. You also, as I mentioned before, had to be on RAS inhibition as we outlined. Now, patients were excluded if they had IgA vasculitis or a secondary IgA from another condition. Also, they were excluded if they were on systemic immunosuppressive medications for more than 2 weeks within 3 months of screening. We see some comorbidities there that were excluded, specifically hepatic, cerebrovascular, cardiovascular comorbidities. And also if you had crescentic disease, so cellular crescents greater than 25% on the biopsy within 6 months of screening, you were excluded. One note is that our exclusion criteria, there were no exclusion criteria for BNP levels or for anemia. Here's the proteinuria reduction over time. And so we see a few things here. Number one is that the response to sparsentan is very rapid, right? So right when we see these patients at the 4-week mark, we already see a very rapid reduction in the proteinuria. And recall that there was no washout period in the PROTECT study. So this is an additional improvement on what they were on previously, which was a max tolerated dose of an ACE or an ARB. So we see that additional benefit in proteinuria reduction. We also see that the response is sustained, right? So we see that rapid drop, but it's sustained over the 110 weeks. And so we're comparing sparsentan there in the teal bar to irbesartan in the gray. And so obviously these differences were statistically significant. We see that when we max titrate irbesartan, you do get some improvement in the proteinuria, but that effect tends to wane over the course of the study to out to 110 weeks, whereas the sparsentan effect remains relatively consistent. Now, another way we looked at that data is not only just showing the proteinuria reduction, but what patients achieve reduction in proteinuria to the point where they have complete remission of their proteinuria or even less than 0.5 grams per day. And so what we see there are the patients that achieve less than 0.3 grams per day, about a third of them in the study, so 31% compared to only 11% in the irbesartan group. So 3 times more likely to achieve complete remission with a single molecule here, with a single medication, than you are with just irbesartan alone. Then we also see when you look at that 0.5 grams per day, which is also mentioned in the KDIGO guidelines, over half the patients in the sparsentan group achieve that urine protein excretion, less than 0.5 grams per day, compared to only 24% in the irbesartan group. Now, looking forward, that was the proteinuria data. We want to see, well, what's happening actually with the GFR? And what we see with GFR is that really the benefits of sparsentan did tend to accrue over time. So these are the absolute changes in the GFR. We're looking at week 6, at 1 year, and then also ultimately at the end of the study. And we see at 1 year, the difference between sparsentan and irbesartan was 1.9 mils per minute. Then we take that forward to 110 weeks, and we see that difference grows to 3.8 mils per minute. So, clearly looking at these graphs with sparsentan in teal, irbesartan in gray, the sparsentan line definitely tends to, appear a bit better, right? That decline in GFR is certainly slowed compared to the people on max labeled dose of irbesartan. Now below, we also have total and chronic slopes listed in the table. And I will point out that both of those, the total slope and the chronic slope differences, were statistically significant. When thinking about this end and trying to explain it to your patients, GFR and proteinuria may be, foreign, values to them that don't make a lot of sense. But I think one thing that all of our patients very clearly understand is dialysis. And so these are data from the supplement of PROTECT, basically projecting your time to dialysis based off of those GFR slopes that we had just shown. So what they did is they took the average starting patient in PROTECT, so a GFR around 56, 57, and what they did is based on the slope, they project your time to dialysis. And here, just for the sake of, kind of coming up with a common endpoint here, we chose a GFR less than 10 as around the time you'd probably be considering initiating dialysis. Obviously, it's based on symptoms as well and not just a number, but just to kind of give us a reference point. So what we see is the irbesartan group, which is in gray. If they're on max label irbesartan at 300 milligrams, we can expect that they will progress to a GFR less than 10 in about 11.2 years. Now, when you look at the sparsentan group in teal, you add 4.5 years of life off dialysis potentially in those patients. And so that's pretty impactful when we think about the types of patients that we're taking care of with IgA nephropathy, right? That means potentially the difference of not being on dialysis, when your child is in high school versus now getting them through all the way to college. That also means as you have more time in that range between 10 and 20, more time to get yourself listed for a transplant, more time off dialysis while you're waiting, and also more time to appropriately prep to start dialysis if you ultimately will need it. The other line here I'm going to show is this deeper purple line. And this is comparing patients with RAS inhibition standard of care. Because as we know, forced titrating all of our patients, counting pills every day to make sure they're compliant is not something that's really done in the real world. So what we did is we looked at some other studies and just looked at their standard of care arm and saw, based on their slopes, how they performed. And there, those same patients now in standard of care, so on some form of RAS, but not force titrated and not specifically closely monitored, we see that those patients end up crossing that EGFR line less than 10 at about 9 years. So when you're comparing standard of care, which is probably closer to what we're doing, to Sparsentan, you're adding almost 7 years, of life off dialysis, which again, really gets these patients who are young through a substantial and an important part of their life. Now, we also looked at the need for rescue immunosuppressive therapy. As many people were talking about wanting to, try to avoid maybe systemic steroids in these patients, right, because of the side effect profile. And so what we see here is that far less people in the Sparsentan group required rescue immunosuppressive therapy compared to the irbesartan group. So 6 in the Sparsentan group versus 16 in the irbesartan group required that rescue immunosuppressive therapy. So again, trying to get your patients to goal with a single medication to ensure compliance, that this again kind of reinforces that. Now, when we talk about safety, we do have to point out some things. And what we saw in the study, the risk of hyperkalemia was relatively similar in both groups, right, owing to the RAS inhibition part of that. We also see the incidence of edema was similar in both groups. Slightly more dizziness in the Sparsentan patients. We also see at the bottom that I do want to call out the transaminase elevation. So 7 patients in the Sparsentan group had elevated transaminases versus 8 in the irbesartan group. And in the study, no cases of liver failure. So now what we want to do is kind of spend our time kind of turning our attention. So PROTECT was the backbone for everything that, that we've done, with Sparsentan. Then we wanted to look at Sparsentan in some different ways, right? So we're going to look at some sub-analyses of PROTECT, looking at different populations. Now, this first sub-analysis that we did was looking at patients that achieve complete remission, because we wanted to see, well, how do they do? What really happens to their GFR if we can get these patients to complete proteinuric remission? So less than 0.3 grams per day is what we're defining as complete proteinuria remission. We also looked at patients with less than 0.5 grams per day. And this part of the study was treatment agnostic. So when we're dividing up these groups to that less than 3 grams per day or less than 5 grams per day, it's treatment agnostic. So we did not care if you got there with Sparsentan or if you got there with irbesartan. And so when we're looking at the characteristics, we see that the patients that achieved either that less than 0.3 grams per day or less than 0.5 grams per day, but in both of those cases, they tended to start with lower median urinary protein creatinine excretions, right? They also tended to have a bit higher GFRs than the patients that did not achieve. Here's what happens though. So we have 2 bars here. So let's start on the right side. The purple bar are the patients that did achieve that less than 0.3 grams per day of protein excretion. The gray or kind of lavender bar are the patients that did not. So we see 2 things here. Number one is that we see there seems to be a bit of a sharper drop there at the very beginning, sort of like we expect anytime we add RAS inhibition. So they had a quicker drop in their GFR, but what really happens over the course of the 110 weeks is after that drop, the GFR remains pretty stable, right? So if you're looking at the eGFR at week 6, the change was minus 3.6 in those patients that had that 0.3 grams per day. If we take that all the way out to 110 weeks, that change in the GFR was -4. So again, relatively stable, where we do not see that in the lavender patients who did not achieve complete remission. So that by the end of the study, the difference between those 2 groups was 4.9 mils per minute per meter squared. And I also would have to obviously point out that in the group that did achieve that less than 0.3 grams per day, the vast majority of them were Sparsentan patients. And that's sort of the donut graph on the left-hand side. 73% of the patients that achieved that 0.3 grams per day were Sparsentan patients, compared to 27% that were receiving irbesartan. So 62 of our Sparsentan patients versus 23 of our irbesartan patients got to that complete remission, less than 0.3 grams per day. Now, we looked at this also with 0.5 grams per day, again, in kind of accordance with what KDIGO was mentioning. And the graphs are very similar. Now, they don't do quite as well here in the 0.5 grams per day. So it does speak to really pushing and trying to get to that 0.3 grams per day goal, but otherwise very similar graphs. And again, on the left-hand side, more patients in the Sparsentan group. So 103 patients achieved this 0.5 grams per day compared to only 48 in the irbesartan group. So again, getting that proteinuria level down as low as possible is critically important to preserve GFR. And what we've seen in PROTECT is that you are more likely to get to those goals if you're using sparsentan versus max label irbesartan. And so here's just sort of a slide breaking down, those slopes. And I would point out, again, for those patients that achieve that 0.3 grams per day, so getting them to what we call complete proteinuria remission, their total slope was -1, right? And that's sort of exactly where KDIGO wants you to be, right? That was that goal we mentioned in the KDIGO guidelines. So kind of harken back to that again, getting these patients to that 0.3 grams per day gets us to where we want to be based on the guidelines, and also to help these patients preserve their renal function. We looked at composite endpoints in these groups too. So on the left side are the patients that achieve that 0.3 grams per day. On the right, 0.5 grams per day. Our composite endpoint was defined by a GFR change of greater than 40%, end-stage kidney disease or death. So our patients that got to complete remission of proteinuria, only one event throughout the 110 weeks. So again, really speaking to the strength of that, compared to the people that did not achieve complete remission who had 43 events. The results on the right-hand side are similar, right? But not quite as good. When you get to 0.5, you're obviously doing better, but not quite as well as you would have done if you got that down to 0.3. But still, 6 versus 38 is again pretty powerful. So we're showing that getting that proteinuria to complete remission slows your decline in GFR, prevents you from progressing to end-stage kidney disease, which I think is, again, very powerful. Now, one other part of data that we looked at when we were breaking down the PROTECT study, and this we have to thank you all, obviously, because this actually came from suggestions from physicians, some of which are members of GlomCon. And what they said is, well, in PROTECT, we really saw the patients that had, greater than 1 gram per day of proteinuria. How do your patients with less than, that gram do? And is the medication effective? And so we did this sub-analysis, looking at patients with less than 1 gram per gram of proteinuria or greater than 1 gram per gram of proteinuria. So if your baseline UPCR coming into the study was less than 1.0 grams per gram, you're on the left-hand side. If you were greater than 1 gram per gram, you're on the right-hand side. And what we saw here is that, again, the sparsentan group, to get to complete remission, did well and in both of these sides. So what this told us is that the results of PROTECT are generalizable to even our patients with less than 1 gram, of proteinuria based on this. Because prior to that, we didn't have strong data to support that use in less than 1 gram per day of proteinuria. And now this sort of reinforces that this is an appropriate medication to consider to get your patients to goal, because we see those sparsentan patients really do a great job of getting to goal with their starting at less than 1 gram per gram compared to the irbesartan group, which does still not do quite so well at getting to that goal. So some high-level kind of summary there on that. Basically, achieving complete remission is the goal, right? A complete remission of your proteinuria. That's associated with better preservation of kidney function compared to people that do not. And we know that our sparsentan patients are more likely to do that than our irbesartan patients. And when we get to that less than 0.3 grams per day, we're basically getting that GFR slope right around that 1 mil per minute per day. And even our chronic slope was even a little bit better. When you exclude that initial drop, it was better than that. So showing that that's really the key. We also showed that in the other sub-analysis that patients with less than 1 gram per gram of proteinuria do quite well on sparsentan as well, with achieving that complete remission. I want to move to a phase 2 study, which is the Spartan study. And now in PROTECT, we were looking at prevalent patients. And so the average time that people had been from diagnosis was about 3 or 4 years from their biopsy. So the Spartan study, again, a phase 2 study, looked at, well, what happens if we get these patients fresh, right? And this is maybe a bit more real world, right? You've made this new diagnosis. So what are you going to do? What medicine should you choose? And so in order to be included, you had to be an adult with biopsy-proven IgA nephropathy within 6 months. You had to have more than 0.5 gram per day of proteinuria. So we did lower that proteinuria threshold sort of in accordance to what KDIGO is now recommending. You had to have a GFR greater than 30, and you could not be on an ACE or an ARB. within 12 months of the start of the study. So again, these are totally treatment naive patients. Also weren't allowed to be on systemic steroids within 6 months of entering the study. We looked at safety, the change in proteinuria, also the odds of achieving complete remission, and ultimately we'll also look at GFR from baseline. Now we have some additional monitoring that we're doing for these patients. So these patients are also being offered the opportunity to have a biopsy at 24 weeks. We're doing some additional ambulatory blood pressure monitoring, total body water monitoring, and even renal and cardiac MRIs. And so this is an ongoing study, so I'm going to present some of the data here, and then we can hopefully, at subsequent conferences, we'll be able to show you more. But patients were screened from day 1 to week 2. They were on 200 milligrams of sparsentan, and then titrated up to the 400 milligram dose. So very similar dose titration to what we saw in the PROTECT study, and they were followed. So here's the results in proteinuria. Recall that when I showed you the PROTECT data, there was about a 40% drop in that proteinuria right away. Here we're seeing even better results, albeit smaller numbers, but what we're seeing here is a 62% reduction in the urine protein creatinine ratio from baseline. And again, that was sustained throughout the 24 weeks and even slightly improved now, almost up to 69% by the conclusion of those 24 weeks. So just like in PROTECT, our proteinuria reduction was rapid, and sustained. Now here are the spaghetti plots of the patients that participated. And the reason to show these is that we did have some patients with very high levels of proteinuria, right? Almost around 4 grams, but we also included patients with lower levels of proteinuria, right? That was 0.5 to 1 gram per day of proteinuria. So again, looking at this in sort of a diverse range of populations and seeing good improvement. So among our patients, the 5 of them that had protein excretion greater than 2 grams per day at baseline, 4 of them had proteinuria reductions of over or equal to 75% at any time during the first 24 weeks. We also were able to show that 58%, so 7 out of the 12, did achieve complete remission at less than 0.3 grams per day at any time during the treatment period. So we are getting patients to goal. You see the one broken line there that's sort of a dark blue, sort of in the middle. That was the one patient in the study that discontinued, and the reason for discontinuation was hypotension, and we'll talk about that, but that's why there's that one broken line there. The other thing we were able to look at in this study, now starting to think about, I mentioned before the anti-inflammatory, anti-proliferative properties of sparsentan. So we started now looking at some urinary biomarkers. And so one that we looked at here was the urinary SCD163. So this is a marker for alternatively activated macrophages, and it correlates well with macrophage inflammation and active lesions in IgA nephropathy. So initially used in the testing study, and what they found in testing is that a greater than 50% reduction in the urine SCD163 levels from baseline was associated with a reduced risk of the composite kidney endpoints. And what we see here in the Spartan study is we also see very similar, right? We see another rapid reduction in that urinary SCD163 level that's sustained throughout the 24 weeks. And that does sort of mirror the proteinuria benefit that we saw in these patients. One of the other concerns or thoughts as well are all these changes that we're observing just a result of hemodynamics, right? We know that RAS inhibitors lower blood pressure. We also know that endothelin antagonists lower blood pressure. So is this all hemodynamic? And these data suggest that that's not the case, right? We see a initial slight decrease in the blood pressure, but then remains stable throughout the treatment period. We're not seeing markedly lower blood pressures after the patients are initiated on sparsentan. And remember, these are new patients that are not on RAS prior to starting the study. So we didn't see that blood pressure come crashing down and didn't see hypotension as a major issue here. We also didn't see any change in body weight, right? So one of the concerns with endothelin antagonists is fluid retention, sodium retention. And throughout the course of the study, we didn't see that. We saw no meaningful changes in body weight over 24 weeks. And really, the total body water change from baseline actually showed some modest reduction during the treatment period. So the weight in kilograms about minus 1.0 kilograms at week 24. Adverse events I briefly touched on, but we'll show them here. Overall, sparsentan was generally well tolerated. And like I mentioned before, one patient did permanently discontinue the treatment due to hypotension, after week 6. So conclusions for this part is a first-line therapy for IgA nephropathy. Sparsentan was generally well tolerated and did lead to that rapid and sustained reduction in proteinuria. And within 24 weeks, about 60% of our patients did get to that 0.3 grams per day complete remission of proteinuria, the treatment goal outlined by the KDIGO guidelines. And we also now start to show for the first time biomarkers, right? So I mentioned at the beginning, we have mouse model data to highlight the anti-inflammatory, anti-fibrotic properties of sparsentan. We're now able to start using some biomarkers to kind of show that correlation in humans as well. So the last study I'm going to touch on very briefly is Spartacus. This is another phase 2 study, and it's looking at the use of sparsentan with SGLT2 inhibitors. In the PROTECT study, patients were not permitted to be on SGLT2 inhibitors because if you think about it historically, when PROTECT was designed and started, SGLT2 inhibitors were not sort of a thing for nephrologists for us to be using regularly. We did include them in the open label study, which we'll be showing at a future date. But Spartacus really looked at, well, how does sparsentan and an SGLT2 inhibitor kind of work together? And so in order to be in Spartacus, you had to be an adult with biopsy-proven IgA nephropathy with a urine albumin creatinine ratio greater than 0.3 grams per gram. Your GFR had to be greater than 25. And you had to be on a stable dose of an SGLT2 inhibitor and RAS blockade for greater than 12 weeks. So what they did is they took these patients on an ACE or an ARB plus an SGLT2, and then at day 0 there, they discontinued the ACE or the ARB and switched them to sparsentan, 400 milligrams per day, plus the SGLT2 inhibitor. So the SGLT2 stayed constant throughout the course. It was just RAS was flipped and sparsentan was put in. And again, the primary endpoint was that change in the baseline UACR at week 24. We have some secondary endpoints mentioned there, as well, really looking at the change in the urine albumin creatinine ratio. The demographics, these patients look very similar to the patients that we saw, in PROTECT. The urine albumin creatinine ratio was 0.84. The protein creatinine ratio was 1.45 grams per gram. 10 of these patients in the study also did have hematuria, so we are including those in the study. And again, what we see here is sort of the same story, kind of reinforces what we saw in PROTECT. So PROTECT showed that statistically significant drop in proteinuria when you use sparsentan over irbesartan, right? We saw the sub-studies, again, support the use of PROTECT. We saw Spartan show the benefits in de novo patients. And here again, we see that sparsentan actually works quite well when you add it to a stable dose of an SGLT2 inhibitor. You're getting that nice reduction in the urine albumin creatinine ratio. And again, a very rapid drop. Even at week 4, we're seeing a nice reduction around 40%. That's sustained throughout the 24 weeks where we have data so far. And this is an ongoing study, so we'll have additional data to show at the 2025 conferences. We also see in the study that quite a few people are getting to remission here. So that first group, about 16% of the patients got that urine albumin creatinine ratio to less than 0.2 grams per gram. We also see that about a third of the patients have a greater than 50% reduction, and almost 60% of patients have at least a 30% reduction or more from baseline. So really seeing continued improvements in the proteinuria there. And blood pressure, again, relatively stable after the addition of sparsentan, right? So we're stopping our RAS and changing our foundational therapy to sparsentan. And again, a very relatively stable blood pressure there throughout the course of the study. We talk about treatment adverse events here. So 5 of the patients did have some adverse events. The one severe event was an episode of gout. But again, no incidences of abnormal LFTs seen here either. So overall, sparsentan combined with an SGLT2 inhibitor was generally well tolerated. No unexpected safety signals were observed. And so it just kind of highlights again, this is an opportunity because we know that many of our patients are on SGLT2 inhibitors already as they're, good proteinuria reducing medications. And the addition of sparsentan gives additional benefit to these patients in getting them to their proteinuria goal. With that, just a very brief summary before I turn it over to the panelists here. But again, the 2024 guidelines recommend getting those patients ideally to less than 0.3 grams per day to try to stabilize those patients' GFR or at least slow that rate of decline, right? We saw in the PROTECT study that sparsentan showed a statistically superior proteinuria reduction as well as GFR preservation. And again, those proteinuria reductions were rapid and sustained. So the medication is working very early on in your treatment course. to help you kind of guide whether therapies you may or may not need. We also know that these Sparsentan patients were far more likely, so 3 times as likely, to achieve complete remission. Recall, about a third of our patients receiving Sparsentan did achieve complete remission in the PROTECT study. Spartan showed and highlighted the use of Sparsentan in the de novo population, so a new biopsy patient, and we saw the drop in proteinuria was even more profound there, up to about 61%. We also showed the urinary biomarkers, and we will have more data to come there, as well as the biopsy data from those patients. So those will all be kind of stay tuned to come, at subsequent conferences. We'll be able to present some of that data. And then finally, Spartacus showed that really Sparsentan works very well with SGLT2 inhibitors as well to lower that proteinuria and obviously reduce these patients' risk for disease progression. At that point, I'll stop sharing my screen and I can turn it over to the panel for their discussion. But thank you all for your attention.
Thank you, Dr. Gisler, for your presentation, and I'm looking forward to the next 30 minutes or so that we have of discussion. There's been some great questions that have come up in the chat, and I want to say I think all of this new data is very helpful in answering some of these questions as far as, even though they're small numbers, but adding these other therapies as the landscape for IgA nephropathy has really expanded remarkably fast. And so to start off, and before we get to some of the specific questions, maybe Dr. Rizek and Dr. Aurora can just talk a little bit about, very briefly, on high-level basic approach to what they're looking to target in a patient who comes in with IgA, mid-range kind of CKD3 and proteinuria.
Yeah, I think from a proteinuria perspective, I think the guidelines really, truly, if you read the fine lines, did not change a whole lot. So even in the 2021 guidelines, they had recommended or said that ideally you want your proteinuria to be less than 0.5 grams per day. They took it a step forward in the 2024 draft guidelines, saying you need to target 0.3 grams per day. And previously, although this was the ideal goal, of course, then they said if you have persistently more than 1 gram per day, then you need to consider clinical trial or additional treatments, which at the time we didn't have much except steroids, hence, participation in clinical trials. Now that we have a wider armamentarium of drugs that's consistently expanding, I think there is a much better chance we will achieve these new goals, including the stringent goal that Chris talked about, the 0.3 gram per day, which is really what we should be striving for.
Thank you. And Dr. Aurora, do you have anything to add?
Yeah, absolutely. So I think I personally feel that with the newer drugs coming up, and we have now almost 3 FDA-approved drugs, we have a lot more options to offer to our patients. And I think I'm almost playing a catch-up at this time. And what that means is that I have had patients with IgA nephropathy whom I've been following for years who have not reached their proteinuria goals, not even less than 0.5 grams. And they were at a point that they were on RAS inhibition only. And now I have this luxury to say and present them that we have now new drugs with DRA like Sparsentan, and to maybe swap them to the dual endothelin angiotensin receptor antagonist and see if that helps in reaching our goals with proteinuria.
Somebody in the chat just asked, do you think the stringent proteinuria goal doesn't take into account proteinuria due to chronic changes? It does, there's no doubt. So in clinical practice, we look at other parameters. Of course, we're looking at the GFR change, we're looking at hematuria, we're looking at the biopsy, so on and so forth. But honestly, even proteinuria from chronic change, it's pretty clear that if we can reduce it, and again, Sparsentan is well positioned to do that, SGLT2, we shouldn't forget our ACEs and ARBs that have served us well for many, many years. Even changing proteinuria related to chronic damage, glomerular sclerosis, so on and so forth, is still important and still improves people's outcome. So regardless of the source of proteinuria, yes, we need to still strive to reduce it as low as we can. We might not be able to achieve the ideal goal in everybody, but as low as possible.
One thing I wanted to ask about, and I think it ties into some of the other questions that have come up in the chat, is so you, Dr. Gisler, you presented the data on if you achieved remission, the initial drop in the eGFR, right, in both groups, whether it's less than 0.5 or less than 0.3. And individualizing, my question is, how do we then individualize therapy? So that would suggest to me that that patient has some physiologic response to the medication, right, where the others didn't. And so one of the questions that I had is, clinically you may see that, right? The creatinine, the eGFR drops initially, and you say, hey, well, this drug may be working. Is there, there are centers that have biobanks based on the mechanism of action and based on, metabolic clearance and things like this. Is this a drug, a medication that something like that could be looked at, so we would have better individualization of therapy to identify who this will work in and who it may not?
Yeah, no, I think that's a great point. I think that's those are things that we're also now starting to look at, right, as we started to observe some of these changes. So absolutely, because you want to know if a medicine is going to work right away. For now, we don't necessarily have that yet, but we do know that, we see that proteinuria drop relatively quickly. So if you're going to get a response, you're typically going to start to see it, in those early, first 4 to 8 weeks. But I think going forward, we are going to kind of look as you suggested for sure.
And then a question along those lines that came up kind of in the chat that I think Dr. Rizek and Dr. Aurora can help answer too from a clinical perspective and clinical practice perspective. There was a question about clinically we see dosing to potentially be a problem, right, with hypotension. And so maybe instead of the 400 milligrams, they're on 200 milligrams. There may be some other agents that are targeting endothelin receptors specifically. What are you looking at clinically to decide, hey, are we getting the max dose? Should we be changing therapies? Or, is half the dose okay? And I'd like to hear Dr. Rizek and Dr. Aurora, but then we'll come back to you, Dr. Gisler, to talk a little bit about, what is the spectrum of blocking across the effects from a more scientific perspective.
So yeah, I can go first if you need me to. So yes, there are patients that will not tolerate the 400 milligrams per day. Even in the trial, there was a small number of patients that couldn't. The reality of it is that the same thing happens when we put people on ACE and ARB, but it's pretty clear also from all the trials we've been participating in, and I think Chris showed it very nicely, that we also don't push people hard enough with ACEs and ARB, and we probably will do the same with Sparsentan. So I would urge people to look at the patient's regimen, make sure they're not on 2 blood pressure medications, that one of them can go and you kind of push the one that's IgA specific or that has been shown to be, beneficial in IgA patients. Having said that, these are young people, and sometimes truly their blood pressure is low. We see that a lot in Asian patients, in patients of Indian descent. They cannot, they really don't have that much blood pressure to push the medications up. And to me, that's no problem. I keep them on 200 and keep going. The issue of atrasentan having the flexibility, because it's coupled to the ACE or ARB, we can look at it both ways. Compliance in a single pill would probably be higher than 2 pills. And then really atrasentan has a single dose, so there is really no means to also titrate the endothelin inhibition. So if somebody becomes hypertensive, you're back to square zero. But I have no problems keeping people on 200 milligrams, and if I have no reason to believe that they would not benefit to some extent from it.
Yeah, and going over the part B of the question, that are we then affecting the ETA antagonism? I believe, Chris, correct me if I'm wrong, I think the receptor occupancy is up to 95 to 99% for angiotensin II receptors with sparsentan, and maybe close to 65% for the ETA receptors. And I don't know if we have the data on the reduced dose with that. So
we don't. The main thing we have is the data here, and I think hopefully you can see my screen, but these are the data here for the, I apologize, it's the wrong slide. I was trying to bring up something just quickly here to show the receptor occupancy, since that was the question. There we go. Can you see my receptor occupancy data?
Yes.
Okay. So basically what we're showing here is that with sparsentan, we have our sparsentan PK in kind of the teal graph there. But then what you see at the very top line, that's the angiotensin 1 receptor occupancy. So it's essentially near 100% binding throughout the entire day. Then the graph below that you see is the endothelin A receptor binding. So again, it peaks out at maybe right around 75% and then starts to trail off. And then down below, we see the ETB receptor occupancy, which is essentially nothing. So the benefit of sparsentan as a single molecule is you guarantee that you always have consistent RAS inhibition in the presence of endothelin inhibition, right? So we know that unopposed endothelin inhibition can cause sodium and ultimately fluid retention. So we think about blocking endothelin causes fluid retention, blocking RAS causes fluid or sodium excretion, right? So those two, since they kind of oppose each other, you want to be careful in a situation. So let's say if you had both medications, that if the patient said, oh, I don't feel that great today, I'm going to take my endothelin antagonism, but skip my RAS, you may potentially run into some problems there. So that consistent, like optimized blockade of angiotensin with the sort of appropriate amount of endothelin blockade is where we sort of see the strengths of sparsentan, as well as a single molecule, as you all mentioned, so to help with compliance.
And Chris, the data you're showing is for the 400 milligram dosing, right? Just to be
correct. That's for the 400. So we've not had it for the 200, but that may be something we end up, kind of looking at, because you do have a titration option. Obviously, we want them on max blockade, just like we talked about mass RAS blockade. So we want people to really try to get to the 400 milligram dose, but you certainly have an option to do 200 if they can't tolerate it. So you do have that titration option with sparsentan.
And Chris, do we know how many patients in the trial were needed to be maintained on 200 milligram dose instead of 400?
Yeah, so again, we were able to get into the high 90s with our 400 milligram dose. So remember, we talked about that. So the irbesartan, that max label dose was achieved like 96%. Sparsentan was very similar. So it was above 90% even by the end of the trial. It was very well tolerated. And we didn't see that huge, drop in the blood pressures were pretty comparable. In PROTECT, some people were on other blood pressure medications as well. So potentially, if you're noticing hypotension, that would be maybe a thought to pull off one of your other blood pressure medications, an opportunity as well. But if you had low blood pressure issues.
Yeah.
Yes, and then I think one of the questions, so obviously, like you said, a dual agent from a compliance standpoint and a patient's ability to take medicine makes a lot of sense. And then us as clinicians thinking about which blood pressure medications they should be on for tolerance. But then the question we get from patients is, so I'm on this for how long? And that's a question that came up in the chat is what are your thoughts on, I mean, the ACE and ARBs, we tell them yes, for the most part. What is this on your thoughts on lifelong therapy, when we achieve remission, how long, and some of these younger patients, when do you think about maybe do we trial them off or not? Because they're the ones who are going to be asking those questions.
And I apologize, was this for me or for Dana?
No, well, I think for Dana and Swati to.
Okay, good. Yeah, perfect. Okay, cool. I don't leave you hanging here.
So I think of those again as lifelong therapies, especially that, again, when you're talking about proteinuria, for the most part, you're addressing proteinuria related to active disease, but also chronic changes. And there's no reason to believe these would disappear. So if you were to stop the drug, the proteinuria would probably come back. And we will see that probably in the open label extension, or more longer follow-up of these patients from the trial as well at some point in time. The other consideration and thing that will happen in real life is people will stop it, especially young female patients will stop it to get pregnant. And that's, of course, important. So we'll have, again, real life data at some point in time of people coming, starting and stopping potentially the medicine. But yeah, I started just like I would an ACE and ARB and tell people this is a lifelong therapy. Swati, I don't know if you have other.
So my only other thought was, sometimes we have issues with coverage and insurance, and then how much copay and so forth. So that would definitely take a role into that. But I agree with Dana that if patients are tolerating it well and they're responding And yes, we have right now data with 2 years, but then open label extension is ongoing. So we'll get more information as we move forward. But if the drug is working and then we're at our goal, then I don't see a reason to swap it unless there are other limitations with respect to any new side effects or pregnancy, as Dana mentioned, or cost issues.
Thank you. And then one of the questions that had come up was, and this is for Dana and Swati as well, as based on the mechanism, based on this using it as a background, medication that would be lifelong, and its effects on proteinuria, where do you see this going in the use of other GNs and other proteinuric kidney spilling diseases? And then maybe Chris can talk about if there's anything in the works to look at that.
Yeah, so I think a lot of studies are going on. We have the phase 3 duplex trial results published for FSGS, where it did show that more number of patients on Sparsentan had achieved partial remission as compared to patients on the irbesartan arm. And then there is an ongoing trial in pediatrics for a variety of diseases, like they're looking at patients with Alpert's, IgA vasculitis, minimal change. So all those studies are still ongoing. And Chris, if I'm not wrong, the Spartacus trial in ANCA vasculitis, I think, has stopped recruiting, and now, right, the results are still pending. So yes, it is being studied in other GNs as well. So we're still looking forward to the results.
Yeah, I echo what Swati said. So this is, the disease should be a disease agnostic process. Endothelin pathway activation and angiotensin activation is almost universal in glomerular diseases. There was a question in the chat about the FSGS data and why did it not translate into GFR preservation and like it did in IgA, and maybe Chris can address that. I would just say that there's a lot of, so FSGS, as you all know, is a very heterogeneous disease, very different from the primary IgA patients we recruited for the trial. So that's one shortcoming of FSGS trials. And then proteinuria as a surrogate outcome has really so far been proven mostly in IgA nephropathy, meaning in the time span that we used to develop these clinical trials, this was based off of multiple clinical trials in IgA nephropathy that had showed that short being somewhere in the 9-month range, reduction in proteinuria by more than 30% would translate into GFR preservation at about 2 years. That type of solid data is not available from other glomerular diseases. So if studies are designed with that in mind, it may not really translate. That doesn't mean the drugs are not good or not, it's just we have to rethink the study design. And the Parasol effort, which is this big effort to try to identify a surrogate marker for FSGS, really showed that proteinuria behavior in FSGS is very, very different than in IgA nephropathy. So we have to interpret or, kind of draw the parallelism between the two studies with a lot of caution.
Yeah, and also the patients who were enrolled, as in with the FSGS trials, we don't know if this was genetically mediated or immunologically mediated. We don't have any background on how much interstitial fibrosis they had to begin with. So there were a lot of missing pieces in the puzzle. And as Dana said, maybe we need longer term follow-up to see if it makes a difference in GFR in the long run.
And Chris, going back to the individualized approach and what you showed with the IgA of the drop in blood or drop in GFR, do you have data like that on patients who did respond with FSGS that showed decline in GFR and then stabilization in those who achieved remission?
I don't know that we have. Yeah, I don't know that we have anything that we've presented yet. I can tell you, though, certainly with Parasol and looking to establish proteinuria to some degree as sort of a surrogate marker for FSGS, kind of knowing that eGFR is a tough target in a clinical trial over that short period of time because of the way the GFR kind of bounces around in those FSGS patients. It's not that linear decline like we see with IgAN. That we are very excited, right? And so we are actively engaging now with the FDA to kind of reanalyze Duet and Duplex and kind of look forward to see if there's a path forward. Because obviously with our FSGS patients, we do think there's still a tremendous unmet need because these patients obviously do poorly. But we also showed in Duet that in the patients with Sparsentan, about 42% of them got to partial remission. And in that study, we defined partial remission as a urine protein excretion of less than 1.5 grams per day and a more than 40% reduction from their baseline. So 42% in Sparsentan versus 26% in irbesartan. So that was the statistically significant part that was mentioned, there in the chat. But they're correct that the GFR data was rough. So with Parasol now, I think we are hopeful that we'll be able to have some more active engagements with the FDA to kind of get this as a treatment option potentially for our patients with FSGS.
Thank you. And I think we have a little bit of time left. And one of the questions that's come up, and you showed some data on the small group of patients you're studying from day one with biopsies. And so maybe we can talk a little bit about clinically, when do you decide to biopsy someone, and then what helps guide? Does the biopsy help guide your management based on active inflammation, chronic scarring? We talked about using this as a background therapy, so maybe it doesn't play as much of a part in that. But I think it's also interesting that, in the study, anyone with a crescentic form was excluded. If we're thinking about this as a background, someone who comes in with severe, AKI, proteinuria, is this something that we may be putting on with an additional agent? So how do you approach the biopsy in your IgA patients, and how does it help you with management decisions?
So I personally put a lot of emphasis on the biopsy findings, though the KDIGO says clearly do not look at a messy scars as an example. But I think what I look at is how much is the overall inflammation burden and how much is the chronicity. And the way it helps, at least us in deciding as a clinician, like it's not like we should be throwing the kit and thing at every single patient. So I think biopsy does help in kind of dividing these people in two major groups. And so one group could be with non-inflammation, and they have some S1 and T1 lesions, so maybe some sclerosis and tubular atrophy or interstitial fibrosis. So these are the kind of patients I want to maximize their supportive treatment, which would include maybe RAS inhibition or dual endothelin angiotensin receptor antagonists, and then SGLT2 inhibitors to try to reach my goals of reduction of proteinuria. The other piece, the other kind of biopsy findings could be with inflammation ongoing, which I could further divide maybe mild inflammation versus moderate to severe inflammation. So if I'm looking at mild inflammation in these patients, then yes, I want to do my supportive care, but I also want to add something like targeted release budesonide to target the origin of this galactose deficient IgA1, which is the most pathogenic form that has been identified. So I'm trying to target the HIT1 as well as trying to do the supportive care. But if I see moderate to severe inflammation, then maybe up to a few months back, I was relying more on systemic steroids to curb down that inflammation. And now I've moved on to maybe using complement inhibitors upfront. And then if patient is an AKI, rapidly declining GFR, I don't jump on starting RAS inhibition or DRAs on day one as an example. I would want to stabilize that GFR first and then add on my support therapy. But many times, if we're excluding these rapidly progressive IgAs, if creatinine is relatively stable, I don't mind doing things simultaneously as well. But Dana, do you have any other thoughts on this?
Yeah, so I think so the studies, and Chris, correct me if I'm wrong, did not exclude necessarily any crescentic disease in IgA nephropathy. They excluded crescentic disease that's presenting as a rapidly progressive glomerulonephritis. So typically those patients will have quite a bit of crescents, closer to a C2 lesion. The others, obviously, there was no requirement for a biopsy, and the biopsy was done several years earlier. So whether they had a little bit, 1, 2 crescents, 10% crescent, we don't really know. But they were probably included again at a more later in their disease course. So I think, as Swati mentioned, when in clinical practice, yes, we of course look at proteinuria, but we look at a slew of other factors. How old is the patient? How active is the urine sediment? What does the biopsy look like? And then all these kind of factor into our decisions. the argument could be made that even if you have just mesangial proliferation without a lot of crescents and stuff like that, if somebody is young and has a lifelong, you know, to live with IgA, that you should still address the hit one. That's what he is alluding to try to minimize, you know, the constant bombardment of these kidneys, along with managing the chronicity. But yes, and again, you have to think of this as an immunologic disease and kind of the consequences of the immunologic injury all at the same time. That doesn't mean you have to start all these drugs on day one. I mean, it's the idea, I think, that we're trying to kind of emphasize is think of this a little more aggressively. Don't let these patients go, you know, a whole year before you see them back, so on and so forth. So just be a little more proactive and aggressive in their management.
Thank you. And we're back to the top of the hour. So, Chris, do you have any last minute comments or thoughts?
No, that was great. You know, and just to follow up on that just a little bit, exactly right. So it was greater than 25% crescents, and so those people were excluded because they probably that would be someone you would consider immunosuppression on. And so we didn't want to kind of mask the results of the study by people getting steroids. We really wanted to see like what Sparsentan did. But I do think, you know, and most people were thinking about some form of foundational therapy, right, with RAS inhibition. So by showing, you know, that Sparsentan blocking both pathways is just probably a bit better. That might be a better foundation. But I kind of agree, you know, with what Dana and Swati said, that, yeah, absolutely, you want to address issues, maybe not all 100% at the same time, but with, you know, like Dana said, in a little bit more of an aggressive fashion to get these people to complete remission.
Well, excellent. Well, I thank you all for your time. Thank you, Chris, for your presentation and giving us some more information of additional data, different medications we're using concurrently with this. And thank you, Dana and Swati, for your expertise and sharing that with us today, and everyone who asked a bunch of questions that were really enlightening. And hopefully we will have more from you, Chris, in the future to help us continue to best manage our patients.
Yeah, no, a huge thanks to GlomCon from Travere for your great partnership. We really appreciated working with you to help take care of patients.
All right.
Yeah, thank you. And thanks for the audience for being so interactive. It's fun.
Thank you so much.
Thank
This
you.
was a lot of fun.
Happy
Yes.
Sunday.
Thank
Bye.
you all. Have a good rest of
Bye.
your day or evening.